Hello and welcome to another PowerPoint presentation from Western Governors University and the Care of the Older Adult course. My name is Dr. Barbara Dantzler and I am one of the course mentors for Care of the Older Adult. This is the first part of one of your competencies. You have 9 competencies, and this one is talking in reference to planning person-centered care of the older adult. And since that competency has many different parts, this is going to be one of those parts, therapeutic communication with the older adult. The purpose of this presentation is to complement the information available in the course of study, to review the basic principles of communication and provide strategies for communicating effectively with your older adult client. So let us begin by looking at what is communication, what is interviewing, since this is what you will be doing with your patients. Interviewing is the process of communication that is patient-oriented, and when effectively done, is the basis of therapeutic healthcare relationships. It is the core skill of the healthcare professional. This is how we gather information from our patients to develop nursing care plans. Communication fosters a strong client-nurse relationship of trust. So there must be at least 2 persons to have this communication. And for it to be effective, the 2 individuals must engage in processing the information. The physiological aspects of communication involves the brain functioning and our understanding of hearing, speech, and language centers. Cognition is storing the information, receiving information, and interpreting the information. The basis of storing helps to develop emotions, forming judgments, and creating knowledge. Our sensory inputs, such as eyes, ears, feelings, or the sensation of touch, provide the way for the information to enter in our brains and begin the work of the cortex of the brain. The cortex also helps us produce language. And language is the symbols, gestures, and whatever that is common to our group or your culture. Psychological aspects of communication would be the individual's personality, the individual's primary language, whether we are speaking to them in their secondary language, and that will affect their psychological interpretation of the message, their culture, and the history or experience of the individuals. When you say culture, this is very important that we are culturally sensitive and aware that different cultures communicate with one another in different ways. Some cultures, it is okay to stand within what we call our personal zone to communicate. They are more intimate and close when they talk to one another. And for that culture, it is not perceived intrusive, whereas in other culture, it would be. There are some cultures in which eye contact with an elder or a superior is prohibited, where in American culture, it is natural and normal and highly encouraged to make eye contact with the person whom you are speaking with. So these are some of the psychological influences that we have to be aware of when we are communicating with anyone, and especially with our older adults. It also is related to what is the history or past experience says with communication that may have us possibly not make eye contact or to make eye contact but stand afar because of other historical or past experiences. And these must all be taken account of, and nurses should be aware of. Communication barriers. There are physical barriers and there are psychological barriers. Physical barriers. Damages to the cortical centers may be an issue and can be a barrier to communication. Disorders such as aphasia and can be a barrier to communication. Aphasia is a disorder caused by damage to the part of the brain, the cortex, that controls language. It is difficult for the person to read, write, and say what they mean to say. This is usually a result of, or more commonly a result of, a stroke, brain tumors, some sort of infection, dementia, a cognitive impairment, diseases such as ALS, Parkinson's disease, or MS. Dysarthria is when a patient is having difficulty saying words, not because of cognitive impairment, because of problems with the muscles that help with speech or help the person to talk clearly. This also could be caused by nerve damage, muscle disorders of the mouth, the tongue, larynx, or vocal cords. This could also be caused by brain damage, tumors, again dementia, stroke, or traumatic brain injury. Psychological communication barriers. Dementia could be one, mental or cognitive impairment, mental disease, schizophrenia, even depression can cause communication barriers, hallucinations being auditory or visual, embarrassment because of different reasons why there is a barrier to communication, and thus the person psychologically does not want to reveal that because they are afraid or embarrassed, and so they don't speak. English as a second language, when we are speaking to them in English, is a psychological barrier because they cannot understand or they cannot relay to you the message that they want to relay to you. Older adults frequently have psychological barriers, which include being labeled as a complainer if they tell you all the things that are bothering them. They also don't want to provide undue stress on family members or caregivers. They don't want to appear as a burden to the point where you may consider placing them in a long-term care facility. And also, not just with older adults, but maybe even younger persons, if you complain about something and tests are run, you could be revealed that you have a serious illness or disease, and you don't want that news. Psychologically, we will think if we don't know, then it won't hurt us and we can keep on living, or it doesn't make it a reality if I have a brain tumor, but I don't know that I have a brain tumor. So those are some of the psychological barriers that can occur with communication. There are things that happen normally as you age. Not much we can do about them. We can live a healthier life to slow processes, but some things are just going to occur because of our age. Your eyes, there are certain things that happen. You will find more details in your textbook. I'm only going to mention a few things here. The lens color of your eyes may change. Your pupils don't dilate completely, so the size of your pupils change. You will experience difficulty adjusting to sudden bright lights. Night vision decreases. I'm already experiencing that, and I'm still quite young, I have you know. Presbyopia is difficulty accommodating from near to far, which I've experienced too. That's when people start needing to wear bifocals or progressive lenses. Decrease in acuity. There may be complaints of dry eyes and decrease in depth perception. With hearing, there is conductive problems. Something could be blocking the ear canal. Most commonly, it's earwax, but there could be tumors and growths and so forth. Other causes are infections, foreign objects that are stuck in the ear. Hearing loss could also be related to noise pollution, a history of playing in a rock band without using earplugs, or listening to extremely loud music on the headphone sets without too loud. Genetics, toxic substances like the antibiotic gentamicin, frequent hearing infections, a history of otitis media, and presbycusis is the most common cause of hearing loss for an old person, an older adult, I should say, instead of an old person, as I talk about them and myself. So, what are the factors that contribute to effective communication and interviewing? And this is what you really want to incorporate as you speak with your older adult or almost any patient as well. Allow plenty of time for their interaction. Slow down, or the patient may feel that they're not important and you have something more important to do, and they won't talk so that they can free up your time. Set up the environment so that it is conducive to the patient being able to communicate effectively. Use a well-lit room with comfortable seating. Avoid placing barriers such as a desk or table between you and the patient. Eliminate background noise by turning off the radio or television and telephone ringers. And this happens when you're making home visits and you go to see your older adult in their own home. This has happened to me. And they have the TV on and it's quite loud, or they may have a radio on, it's quite loud. And so sometimes I will ask them if they would mind turning it down or off so that I will be able to hear what they want and make sure I am meeting their needs. I always put it on me and not the patient so that they can hear, because that implies to them that they have something wrong with their hearing and so forth. And I don't want to imply that until they tell me so, unless I know it from previous encounters with the patient. What else? Know if your patient is visually impaired or cognitively impaired or has hearing problems as well. And we'll get into like special considerations shortly here. Obtain all necessary equipment ahead of time. There is nothing worse than interrupting the flow of communication and the therapeutic communication, especially when you have to keep getting up, leaving the room to get this equipment, or you have to go to the other side of the room to get this equipment and gather that. It's very disruptive. It stops the flow of thought for an older adult. So make sure you got all your equipment ahead of time. And it could be things like an amplifier for the hearing impaired, an interpreter for someone who needs it. An interpreter can be language or it could be sign language. A message board to write or that the patient can write on, a tape recorder if needed or indicated, paper, pen, pencils if needed. If family members are present, ask them to only respond when asked the question directly. You want to allow the patient to answer for themselves. Sometimes you may have to ask the family member to wait outside because the patient either may be reluctant to speak in front of the family member or friend, or the family member or friend keeps answering for the patient, and that will cause an issue. So you can ask them to step outside and you can explain to them why. Direct your communication to the patient. Look at the patient, not at the family members, not at the friends that came with them, but at the patient. Introduce yourself by name and your role. Hi, my name is Barbara, and I am a nurse here on the floor in the clinic. And I am going to be interviewing you today so that we can develop a plan that will help you with whatever outcome that you are wanting to meet. So you need to give them your name, your role, and state the purpose of the interview. And then tell them or how much time is needed to reach this goal. Determine how your patient likes to be addressed, okay, and call that patient by that name. Never use terms of endearment such as honey or dear. It's not appropriate, and it's a habit that I have because of my southern upbringing by saying honey, oh sweetheart, and so that is very inappropriate. So I have to be conscious of what I'm saying when I'm speaking with my patients. And extend your hand and shake gently your patient's hand and smile. Okay. Show attentiveness to your patient and listen. Be quiet. Be silent. Allow the patient time to get their point across and process information. When older adults are rushed, they lose their train of thought, the same as when there are frequent interruptions. You also send a message that you do not have time or you do not want to spend the time with them. Share what you think they are trying to say. This helps validate and ensure accurate information is relayed. Do not talk down to the patient or lose effect in the process of simplifying speech or making it elementary to the patient. Slow your rate of speech, which is something I personally have to concentrate on because I am a fast talker. Do not use jargon, but use simple and exact language to make certain all communication is understood. Body language should match the message. Avoid crossing the arms, sighing and taking deep breaths as if you are tired or impatient. Avoid tapping your pencil or pen or shaking your foot or your leg. Lean forward toward the patient to show that you are interested in what they are saying. Maintain eye contact if it is culturally appropriate, as we talked about earlier. Again, remain silent when the patient is speaking. Try not to interrupt them, okay? And pay attention to their nonverbal communication. Do not minimize their concerns. Do not say, oh, that's okay. Oh, a lot of people do that. Oh, you'll be all right. That's not what you want to do. Use appropriate touch. Remember the handshake in the beginning? That can give you a clue to whether that type of touch is acceptable to the patient. And I say appropriate touch because there's always someone out there that will misinterpret using touch. Okay? Touch can be useful. It can convey understanding, warmth, and caring. A soft hand on the shoulder or just holding the patient's hand while they are talking to you and looking in their eyes can give the message that you are really caring and sincere about what they are saying. Repeat and rephrase the message. If the patient does not understand what has been said, obtain feedback from the patient to make certain that the patient has understood what has been said. And then this way you can avoid any misunderstandings. Provide written material whenever possible. If you have an older adult, provide written material maybe in a larger font size, very clearly written, so that they can read it and understand it or have it for recall later after they leave or go home. And toward the end of the interview, repeat important points, summarize the conclusion, and always ask before you leave them if there are any questions. and give them an opportunity to think about it and ask them. Do not rush them at this point. How to communicate with patients who have a hearing loss. Older adults may not always admit they have hearing difficulties. I said earlier to you, some things can be embarrassing. Older adults will avoid socialization because of the inability to hear and be lost as a part of the communication, and it's embarrassing and hard for them. So they will isolate themselves, which also can lead to depression. So you want to assess your patient if you already don't know they have a hearing impairment, and if they do, you want to get help for them. You also may look for clues. If you are interviewing a patient and you don't know whether their hearing impaired is a problem there. If they have their TVs excessively loud, the radios excessively loud, that may be a clue. If they speak very loudly to you because they're unable to hear how loud they're speaking, that's a clue. They sometimes will pretend that they understand the conversation and they'll just nod and smile. And they will repeat what has already been asked, or they will repeat what you've already said or explained. They may respond to you inappropriately, complain that others are mumbling, You may notice that they tilt or cock their head to one side. And so these are some clues to a patient may have difficulty hearing. And again, you may want to refer them to someone to have their hearing checked and possibly get a hearing device. Shouting in this situation does not help with hearing what is being said. Shouting only increases the intensity. So you do not want to shout or use a high-pitched voice because the high pitch is also difficult for them to hear. If the patient cannot hear, they may read lips. So do not cover your face with your hands or other objects so that they can read your lips if that is what they do. If they have a better ear or they hear better on one side, then gently focus to that side. You may position yourself to that side, but focus to that side. Gestures and pointing can also help clarify the information. Again, you need to turn off the TV, turn off the radio, find a quiet place to conduct the interview if possible. Be attentive and don't try to anticipate what the client is going to say. Allow them to finish. Let them finish. Encourage reminiscing because it can be fruitful for the older adult and it allows them to recall pleasant memories and that gives them comfort. If they have a hearing aid, turn it on. If you have visual aids, such as a writing board, paper, pencil, and pen, computer screen now with technology, you may need to use this, so be prepared to use this. If they have a hearing aid, one of the best things to do is make sure the hearing aid is on. It's sort of like watching trying to figure out why the TV is not working, and it's because it's not plugged in. Same thing with the hearing aid. Make sure it's on. How to communicate with a patient who has visual impairments. Pretty much the things that we have said previously apply in this situation as well. And if you have a patient that you have noted visual impairment, you may want to refer them to optometry or ophthalmology. Remember, vision loss can lead to isolation and depression. So you're going to look for those things. Patients won't socialize if they can't see. They may not communicate with you because of embarrassment. They cannot read certain things, and this is also embarrassing for them. If they have some vision, then you want to position yourself in that field of vision. If they have any or they voice to you that they see specks or floaties, or they appear that they're waving their hand in front of their face as if to get rid of something that may, like a gnat that's flying, recognize that that could also be a sign of visual impairment, because often they do have these flecks, and it has been misinterpreted as they are having hallucinations, but that is not the issue. It could be a visual disorder. Make sure that there is ample lighting in the room, and this also applies to hearing impaired as well as the visual impaired. Don't sneak up on the patient. Don't startle them. Don't come in and holler in the ear, hey, really loud, because they're already in an unfamiliar area possibly, and you're going to walk in knowing that they have an impairment and do that. It's fun when you're young and your heart is good and you do this to your friends and your kids, but it doesn't make for a very therapeutic communication in this case with your older adult patient. You want the patient to be relaxed, and this is in all situations. You want them to be relaxed and comfortable with speaking. But if you have a patient who has one of the speech language impairments that I mentioned earlier, aphasia, dysarthria, had a stroke or whatever, you want to provide, again, another relaxed environment. Losing the ability to say what you want is frustrating. I have had a patient who had a stroke, and this is what was left. She was unable to recall the words that she wanted to say, and often she would recall the wrong word, and so she would become very frustrated and discouraged. And so we would use alternative ways for her to communicate to me, and she could understand what I was saying, but she couldn't get me to understand what she wanted. So remember that it is a very frustrating thing. So you want to provide an environment that the patient is comfortable in, and there are few distractions and no interruptions. Watch the patient for nonverbal cues, as I did with my patient. Facial gestures, their hand signals, signs, pointing, and so forth. Use short sentences that the patient can also answer to you in short words or short and simple. It makes it easier. Maintain eye contact the same as you would with the other types of interviews. In some cases, you may have to bring out a whiteboard or a computer, or paper and pen, the pen and pencil the old-fashioned way, so that they can write. Do not correct everything that the patient says. Well, you already know that there may be some type of impairment, and to correct them each time will damage their self-esteem and also take away their desire to continue communicating with you. You can also set an example for the family by accepting the patient's disability and demonstrate how to communicate with them in a less penalizing manner. Again, repeat and summarize the message back to the client to check for accuracy. If you have a patient with cognitive impairment or has dementia, it depends on how severe the level of impairment is. Sometimes dementia has gone to the point where the patient is not verbal to you at all anymore, and they do not respond. That does not mean that you can speak to them in any manner, because they still may have the ability to listen and interpret the information that you're giving them. They just may not have the ability to relay a message to you. So in the early stages of Alzheimer's disease, is one type of dementia and the most common, the patient may experience difficulty in finding the correct words, such as with aphasia after a stroke. They cannot often recall the names of common everyday items or people. They also may substitute new names for the lack of ability to recall the correct name. So be aware of that. They become very frustrated and they become very depressed because of this inability to communicate with you. And you have to be cognizant of that. They can also become agitated and lash out or shut down. Okay, so be attentive to their responses that they are giving you. Watch for those frustrations and adjust accordingly. Sometimes the use of simple gestures or visual aids that they are familiar with may help the patient with the message and remembering certain things. You, however, must remain calm. Be careful of your own nonverbal cues. You don't want to appear aggravated. You want to remain in a calm demeanor, and this will more likely keep the patient calm and develop a relationship of trust. Keep your voice low and consistent. Don't shout or raise your voice. Shouting in this case can startle the patient, and it can also cause them to become agitated and lash out. If allowed, a gentle touch can be helpful. Try to be at the eye level with your patient, not above them. Okay, this will prevent them from feeling defensive or vulnerable. Tell the client, the patient, your name, your position, the reason why you are talking to them, and refer to the client by the name or however they like to be addressed. And that's in all cases as well.